Good afternoon and welcome to AARC's Behind the Breath podcast, where we dive into the stories and the science and the spirit of respiratory therapy. I'm your host, Monique Kimmel, Vice President of Membership and Customer Care at the AARC. And today we have a very special live episode with AARC member Chief Master Sergeant James Woods. I'm going to take a breath because it's a long title. U.S. Air Force Medical Command Senior Enlisted Leader and the Chief Medical Enlisted Force at the Office of the Air Force Surgeon General. James will take us deep into the world of military respiratory therapy, sharing his journey from becoming an RT in uniform to leading at the highest enlisted levels of Air Force medicine, from deployments to critical care air transport teams, and even shaping the future of military healthcare. This episode brings the heart of an Air Force RT to the mic. Whether you're a civilian RT, military medical professional, or just curious about healthcare in uniform, you're not going to want to miss this behind the scenes look at life, breath, and service. So let's get started. James, again, thank you for being here today. Can you tell us, we'll just start right off the top, how did you first become an RT? And then also, what led you to becoming an RT in the military?
To be honest, I'd always really wanted to serve in the military, and as a kid, I wanted to be an F-16 pilot, and growing up, that's probably what I intended on doing, but I'm green deficient on my color vision, so that eliminated that. And actually, my daughter, my middle daughter, she's actually in Pensacola now training. She's not going to be a pilot yet, but she's going to be a combat systems officer, so she'll sit in the back of an aircraft, hopefully an F-15, and be almost like Goose on Top Gun, and control the weapon systems in the back, so she's kind of leading from the front there and kind of doing things that I wanted to do when I was younger. But that's something I really want to do, but being green deficient made that hard to accomplish. And my aunt at the time, she's a nurse, and she still is a nurse, but she was an inhalation specialist way back in the day. And cardiopulmonary technician was what we were called then. Mm-hmm. And really, that's the only job I was interested in. She talked me into it, told me what I would be doing. I didn't know it would be all the stuff that I got to do in my career. The recruiter didn't do a very good job on advertising exactly what our roles and responsibilities were. It was a very small blurb, but that's the only thing I put on my dream sheet, and I got selected and I got to go. I waited about 6 months in a delayed enlistment program, and actually when I was in basic training, they came to me and they were like, "Hey, you're going to go be a cardiopulmonary technician, but we're taking on more guard and reserve individuals, so we're not doing many active duty at this time. So would you like to cross train and do something else, or you can get out?" And I was like, "Well, I'm not going to do anything else." And that's the thing, when you come open general, you could be thrown in, I could have been in security forces or whatever. I was like, "Nope. My contract was cardiopulmonary. Either I'm doing that and I'll be on hold status, or, thanks for giving me the opportunity to go to basic training, but I'll go home." Luckily, it opened back up, and I was able to go to tech school immediately after that. And I've never really looked back. It's just something I always wanted to do, really, because I was directed by my aunt to do that. And I've got to do some really cool stuff, and I wouldn't trade it for anything. And we have a lot of individuals that get out and do great things, but I got lucky, and it's not really luck. I joined in 1999, and 9/11 happened probably a year after I had graduated from school, and I was working in San Antonio at Wolford Hall Medical Center when it was a level 1 trauma center. And I immediately rolled out the door doing critical care transport team. And my experiences doing that and taking care of our warfighter and taking care of our dependents as well, worked a lot of time in neonatal and pediatric, kept me in the Air Force, and I didn't get out because of the experiences I got to do. And I really wanted to share my experiences with others and try to get people to stay in and do those things. But unfortunately, the military is not for everybody, and it's a great experience for a lot. And then they go off. You do a lot of growing, and then there's other things that you want to go do. So doing 20 years is not for everybody, but it's something that I really enjoyed. Sorry,
that's
long
great.
answer.
No, it's great. And I love to hear this because so many times when we talk to people, they have a story, they have something or somebody who led them to get into respiratory therapy. So, and with you, the combination of the military. So thanks for sharing that story with us. What does a typical day look like for you as an RT in the military?
Well, for me, it's completely different. I am fortunate enough to represent all enlisted medics in the Air Force. So it's a wide range. I have 17 different enlisted specialties. You have your respiratory therapists, you have pharmacy technicians, radiology. We have our like LPNs. We call them aerospace medical technicians. We have our administrative technicians. Just a huge gamut of different specialties out there that I actually get to represent. And my boss is the Air Force Surgeon General, and I sit right next to him on a daily basis. And I'm really his right hand man when it comes to advising him on what the future of Air Force medicine needs to be and how our enlisted medics can get after that and what we need to look like in the future. So my job's a little bit different. I'm constantly in the Pentagon or over here in Falls Church, Virginia, working in the Defense Health Quarters building with the Defense Health Agency, and my boss is shaping the future of medicine. So constantly travel all the time to go see what our medics are doing in our 76 military treatment facilities and our medical groups that we have throughout the world. So my day-to-day is a little bit different. A lot of meetings, working all the time, either at home or traveling. But for our Air Force RTs, it really all depends on where they're located. We tend to predominantly be as an RT in our bigger facilities that we have. Again, we have 76 medical groups throughout the world, but a lot of those are really, really small clinics that we have because a lot of our Air Force members fight from the base. So we support them by keeping little medical clinics so they can stay healthy and their beneficiaries can stay healthy so they can fight that fight. But in our larger institutions like in San Antonio, in California at Travis Air Force Base there, that's usually in those big places like that. That's where we have our respiratory therapists at because that's where we have our inpatient facilities, cardiology, we have pulmonary, we have sleep lab. So it really all depends on where they work. We have a few overseas locations in Hawaii. That's where we have active duty CCATT teams that are there that are really traveling and going to Japan and some other locations and picking up some of our neonates and babies and some of the dependents elsewhere and traveling back and taking them to either San Antonio or Travis so they can get higher level of care. But really it all depends on where we have them assigned to. Our wartime mission mainly is critical care transport team, but also we support EMEDs, which is kind of our Role 3, Role 4 hospitals that we have. But we're transitioning. The Air Force is in a phase of creating deployed combat wings and starting up Role 1 and Role 2 capabilities. We're kind of taking over what the Army and Navy did because we're going to fight differently in the future for large-scale operations. So RTs will be further forward on the ground than they ever have been in the future, predominantly in Role 2 and Role 3s and different island chains depending on where we deploy them. So all that's shaping up and be different. So depending on where we station them at, and usually people do 3 to 4 years at a time, their day-to-day ops is going to be completely different based on where they're at. If you're at Travis Air Force Base, where we have a heart, lung, and vascular center, they're going to be significantly more busy than places at like Andrews Air Force Base down the road that we have here in Maryland. They don't have as many patients unless they go down to Walter Reed and they're do a couple of rotations down there to get their sets and reps. San Antonio tends to be pretty busy and BAMSy, but then we have sort of little offshoots where we have smaller facilities that are more clinic based where they could work in cardiology or pulmonary or sleep lab, but they still have to maintain those sets and reps. They have to get out, and if they don't have the ability to do inpatient care in the facility there, then we have TAAs and MOUs where they go off to a civilian location where they can keep their skills up. Because again, our wartime mission is to be a respiratory therapist when we deploy, not to work in cardiology and pulmonary. So they got to keep those skills up. So it's a long answer for it. All depends on where you're stationed at. If you're on a deployed UTC, so it changes, and it's kind of a nice break. You can't be running 24/7 all the time. You can't be constantly deployed all the time or ready to deploy. You got to take little breaks. That's what's nice about the military. You can move from base to different locations. You don't have to stay in one spot, and it's harder to get burnt out. Now, some places you can because they could be. There's some people that get stuck in San Antonio for 10 plus years and they're constantly jobbing it or constantly deploying, and those people can get burnt out. But we have a pretty good work-life balance in our career field.
It sounds like a lot going on. There really is no typical day to day. How does being an RT in the military, just sort of the nature of what you do and the care that you give, differ from more of a traditional RT who might be in a hospital or in a clinical setting?
I would say the biggest change is, the biggest difference is the leadership opportunities that you're given. As a younger RT, you're given the opportunity to lead either night shift, day shift, or even actually a clinic, a pulmonary clinic, sleep lab. And then as you progress in rank, you can actually end up being like the COO. I was the, how would I say it, the of Human Performance Wing senior enlisted leader that had over 1,200 people that worked there doing research, doing readiness training for CCATT. And I was at 19 years of my career. So I was the wing commander, ran the whole thing as the commander, and I was their COO. And there's smaller scales to that. When I was at Nellis, I was the like the COO of the uh, trying to use civilian terms here, as a surgical operations. So we had radiology, we had cardiology, pulmonary. We didn't have the inpatient, but we had about 300, 400 people. So I was in a leadership position to be able to do that. So we're able to grow. We have more leadership opportunities, and we're able to send people to professional military education where we teach them how to be leaders early on in their career. That I think a lot of our civilian counterparts don't get that until they get farther up in their career.
Interesting. Boy, a lot varied work, but also some great career ladder moves. I mean, just it sounds like in a lot of different areas and different ways to get that management at a young age, which I know a lot of our younger RTs and students really aspire to. Are there any additional, being in the military and being an RT in the military, are there additional certifications or training that you receive that the civilian population, besides just the military scope, but as an RT that might be a little bit different from the civilian RTs?
I am going to drop the ball on the amount of certifications that's out there. Being an NCO or a senior NCO in the Air Force, we have a thing called COOL, and I can't remember that exactly what it stands for, but it's like a repository of money that you can go out there and you can pay for various certifications. Being an NCO and senior NCO, and I think the Army and Navy have their own version as well. You're able to take project management certifications and other things that will help you for a higher level job if you don't want to do RT when you get out. You can do other things. We have, again, professional military education as an enlisted member. As a junior member, I go to Airman Leadership School before I can take on any airman and be a supervisor of those individuals. Then we have Non-Commissioned Officer Academy as you progress in rank, and it's just even more tools in your toolbox that you can put in there. And then you have Senior NCO Academy, and then the highest level one when you make E9, the highest rank you can in the enlisted for the Air Force is you have your Chiefs course that you go to, and it's changed. They're bringing it back. When I went, it was like 4 weeks at Maxwell Air Force Base in Alabama, and it's just ties it in and just way more leadership experience. And then I was on the command chief list, which is a command. Well, that's exactly it. Where you can be the command chief for like larger installations, and it's just even more education. It's just tons of military education that you get. And then there's other master's level programs that you can get into depending on what you would like to do. There's just tons of different opportunities to get certifications paid for and degrees that we haven't really highlighted enough to you all, to the civilian RT community, like what we actually get in the military.
It sounds like so many different tracks you can go
Oh,
down.
there's
So,
tons,
yeah.
tons.
Oh. So I know, as I understand from your background, is you've had a lot of deployments and a lot of overseas assignments. How does that impact your role as an RT?
For my deployments, to be honest, it's really is what kept me in the Air Force, and it's really drove me to take various jobs. I've had the privilege to kind of either teach early on in my career. After I'd done a few deployments, I went and taught. I was the program director for our course, our respiratory course for the Air Force before it moved to San Antonio. And really doing those deployments kind of drove me to kind of bring up the future because I kind of saw like what I wasn't taught and what I was lacking, and I kind of wanted to grow the next me and make a better version of myself. And the same thing, I went off there. I went to Travis Air Force Base, and an opportunity came up to go to Cincinnati to teach at our C-Star site there, which is our advanced course for CCATT. Like people have to go there. We teach them. It's the highest level version for critical care transport team education, and then we actually validate them. It's like a check ride. We go put them through tons of scenarios, and we make sure they're good to go so they don't cause any harm to the patient and like downrange. I mean, that's when you got to be on your A game, and I got the privilege to go there and kind of run that program. And as a critical care transport team, you have a doc, a nurse, and an RT on that. And it was something that started in the late 90s, and after 9/11, it really kicked off. And CCATs and air medical evacuation was really what contributed to a 99% survival rate. If our warfighters made it to a facility that a 99% chance of survival, really because of our en route care mission that we have. And we RTs have contributed to that significantly. And that's really what's drove me to continue to teach and grow the next me. Because I, saw people make mistakes early on in my career and in deployments, and that's one reason why we've created these educational platforms like Cincinnati. We have a platform in St. Louis and Baltimore. We're opening one up in Minnesota, in Minneapolis at the Boston Eye. I just got back from last night. And then we have one, I think I mentioned St. Louis already, and then we have one for infectious disease in, where's that at? Omaha, Nebraska. We've stood it up there. So it's, I've either had to get to teach it, or I've been a leader in one of the organizations that kind of led all those instructional facilities, or directed policy for that. And now I'm in the top that you can go, and I'm constantly advocating to continue this and make it better, and make sure our RTs, our nurses and docs have what they need to be successful. Because the warfighters, I have plenty of friends that are trigger pullers, and they say that they do the mission because they know there's people like me there that's going to take care of them if they get injured.
So now you're at a point of your trainers, and you've probably done a lot of that throughout your career. So,
Yes, ma'am.
which is great. As a member of the AARC and of specifically of the Critical Care Transport Specialty Section, what resources do you look to the AARC to help you within your career?
Really, being a military member, we are tied to fiscal constraints, budgets, and if you're not tracking or watching the news, the administration, we're shrinking on TDY. For us, TDY cost is our going to like AARC conferences and stuff like that, and readiness things and whatnot. We're cutting back to make sure we're spending money on things that we need to. So it's been awesome that AARC, in my 26 years as an RT and being in the military, my membership has always been free. And I don't know if many people know that. It's been awesome. It's been free. But where I can't send a lot of my members, because the way our budget is tied to, our budget's tied to, for our members in medical groups, is tied to DHP dollars, which is the Defense Health Agency money. And that money is healthcare delivery. So if we go TDY somewhere and we're taking money from that healthcare delivery budget, and that means if I lose a nurse practitioner, a PA, and family practice, I might not be able to buy them because I don't have that budget to pay for it, because it's all in one budget. So we have to slim down on some of our TDYs and getting those CEUs that we need. So AARC, giving that free benefit, having those online CEUs that our members can get, it's been extremely beneficial. And to be honest, our members don't use it enough. We're making an effort on the Air Force side to push that out there and say, hey, you all need these CEUs to maintain, and you get it free from AARC. Go online, look at the journal, knock it out. So that's been invaluable to us, especially in this budget constraint that we're currently in. We're going to leverage that more and do that. But really, and I know it's one of the questions that you'll probably get to, what I would love to see AARC do more of is that the advocacy on our part to get after things. The nurses and the docs have great communities that advocate for us on the Hill. And with Congress, my boss and I get to go talk to Hask and Sask all the time, our service arms committee, and the House side of it as well. We go and chat with them, but we haven't really had that advocacy from the RT side, and that's really our fault because we haven't really said, "Hey, we could use your help on this stuff." So, and I think that's something myself. I'm not the head of respiratory therapy. I manage all of the enlisted specialties. Chief Master Sergeant FAM, my 10 FAM, she's the career field manager. She works right down the hall for me. So we'll probably be talking to you all in the near future. Be like, hey, how can you help us out? Because we years ago when I was younger, I think we pushed to be officers, but warrant officer is now a option that the Air Force has brought back, and that's something we might talk to you all about in the future to help be our voice to Congress on. Making that the next step for us, and then maybe we could pull in some civilian RTs to join the family as well.
No, that's great to hear. And we do have a very, very strong advocacy department. So I'm sure that they would love to hear from you and see how we can work together on these types of things. You've had a chance to visit and work with medical professionals who prepare the Air National Guard medics for critical care transport teams. What does that process look like?
To be honest, it's exactly like our reserve and our active duty. If it's a brand new member that's never been an RT, we have about a 3 to 4 month phase one program where they come in straight out of basic training. We give them the the background information, the didactic, and then we send them off for about 8 months to a phase two site where it's straight up 8 hours a day doing clinicals, and they're getting a little bit of didactic, but it's mainly getting clinicals, getting that hands-on time. And then if they're guard or reserve, they go to a phase three, a little bit more hands-on time before we send them off to their unit. If you're active duty, it's like on-the-job training. It's like orientation on steroids. They'll get to their first duty station and they're jobbing it daily. And we have a checklist and we have a training plan that they go through. And before we allow them to deploy or really be an RT on their own, it's like, again, it's an orientation on steroids. Guard and reserve, it's more hands-off. They'll go and they're required after they do their phase three they're required to get a job in the civilian community. A long time ago when I was young airman, it was not. We had a lot of individuals as bankers, they're postmen, whatever. They did their own thing, and then when they deployed, we didn't have good patient outcomes because they didn't practice as an RT. Years ago, that changed, and we made it's mandatory that they do so many hours a month as an RT. So we know some people have their own little things that they would like to do on uh, their personal time or other jobs that they would like to do. But if you're going to be an RT in the military, Guard, Reserve, or active duty, you got to be doing that and know that skill set. So it's kind of the same, but then as a Guard or reservist member, your primary job is really to be a respiratory therapist on the back of a critical care transport team. That's really your job. So they get pushed a little faster to go to CCATT course. Our phase one is in Dayton, Ohio for our initial course, and then the advanced course is in Cincinnati. They'll go through that, and then they have to go back every 4 years to revalidate because sometimes people lose their skills, or it's a very demanding course, and we want to make sure you're good to go. But also the equipment and the bag sets. Yeah. When you fly on the back of a critical care transport team, you carry about 2,000 pounds of supply and equipment, and you got to really know where all that stuff is. So it changes ever so often, and so when they come back, it's just kind of not everybody has that equipment on hand because we don't do CCATT on a daily basis. I wish I could, because I would still be doing that. I wouldn't be on the job I am now. But really, we only get to play with that stuff when we go to course or when we actually get deployed. It's something that we don't get to do on a daily basis, unless you're in Hawaii and that's your sole job is to do CCATT. But we have very few locations. That's the only thing you're really doing.
How do you prepare mentally and physically for the high stakes profession of medical transport?
For me personally, and again, everybody would have a different answer on that. It's really be physically ready, and that's going to cover down on if you're physically ready, you're probably going to be mentally ready. And it's those missions, we are flight crew, but we don't wear wings. So when we're deployed, I could be up already for 10 hours, and then right before I'm getting ready to go to bed, I get a phone call that something bad happened, and we got to go pick up a patient, and then I'm up for 8 more hours. So you have to be physically ready to be able to have that resilience to stay up for those long amount of hours. Hopefully, you have a chance to take a cat nap while you're flying into a location, pick up that patient, but you don't always have that luxury. It all depends on where you're at. So I think being physically prepared is probably the number one thing. And then having trust in your team, because again, it's not just you. You have a doc and a nurse on board, and you got to trust that your team knows what they're doing and they got your back.
How do you, for those who really have not been exposed to it very much in the civilian RTs, what might they not understand about what you do and the nature of your work as a military RT?
I'd say the biggest thing, the nice thing about being a civilian, and my kids would probably say this too, is like you get to pick where you want to live. And that's probably the biggest complaint my kids did was like, I'm from Tennessee, so we never really lived near family. So that's probably the thing they miss the most. But they've got to experience things that other individuals have not got to experience. So they'll say they enjoy that part of it. But really, it's you're probably going to move every 3 to 4 years. That's probably the biggest change that people don't understand. But it is a positive thing. I've got to live East Coast, West Coast, Las Vegas. I've been all over, and I've got to work with some extremely talented individuals. Built relationships with docs and nurses and other healthcare professionals that you might not get just working in one location. And then just being in Minneapolis, I ran into people that I hadn't seen in forever that are actually Guard members that I've known for over 20 years that they're doing great things and standing up CCATT program that's there. And it's just, you build lifelong friendships that you might not be able to talk to that person for 10 years because you're just busy. But when you meet up, it's like you just saw them the other day.
I'd imagine too, just being able, as a family, just being able to adjust and be flexible to your surroundings, having needed to just adjust so many different times is probably a benefit too, or a positive. What advice would you give to somebody who's considering going into the military as an RT?
I mean, for me, I think change, it's just a human thing that people are scared to do, or take a chance on something. I would say I mean, really, the water's warm. It's great. I've been in for 26 years. If you're interested, pick up a phone. I mean, I can put my email on there. Actually, you can look it up. It's easy since I'm a government employee. It's james.woods.9@us.af.mil. And if you all have questions, feel free to hit me up. It's been something that I would not change for anything. It's been the best experience, and I'm glad that I did it. And my middle daughter she's an officer. She's a second lieutenant. And then my youngest just got accepted to Texas A&M in the engineering program, and she'll probably join and be a aerospace engineer when she's done. So she'll be a nerd and be in our research labs that we have. So it's good to see that they're joining in my footsteps.
That's awesome. Congratulations on that. That's
Thank you.
great. What is one thing or a couple of different things maybe that you've learned being an RT in the military that has sort of changed how you see respiratory therapy?
Really, I think when people join, it's everybody, you're like, oh, my job's the most important. But I would say growing up, being a young airman and being a young respiratory therapist, I was like, man, my job's the best thing. Like, there's no other job out there that's better. But growing up and seeing how important everybody is to patient care, and like getting that patient from being their worst day to seeing them walk out the door, is probably what's changed for me in my military career and growing up, and seeing like we play such a huge part, but we're such a little part of that as well, and how it takes the whole team to make sure the patient gets what they need.
That's awesome. Thank you again for joining us today. Really, really appreciate that. Did you have any last thoughts? Did you want to talk about anything to those who might, again, be considering going into the military? What are some, besides all the things that you've already listed, is there anything specifically that you might want to bring up?
It's so many opportunities in the military side that we've not captured. And if you all came to AARC, the Congress in November, I think we had a huge turnout. We had an RT little display there, and I think we'll probably do that again for the next Congress. I cannot be there due to some other meetings I have to be at, but we haven't really showcased what we bring and the goodness that is the military. And it's really, again, I wouldn't change for what I've done in my whole career, but we haven't done a great job of recruiting non-RTs and training them up. But there's so much cool stuff that we do, and there's so much experience out there, and there's such good leaders in the RT community on the civilian side. We'd love to have that talent and show you all the cool stuff. I mean, flying on the back of an aircraft for 8 hours and taking care of a really sick patient, and then seeing those people years later, I don't know, there's nothing that beats that feeling of like seeing the gratitude people have. And I never saw myself as somebody that was doing anything important. I was just doing my job. But talking to those members, seeing like a quadruple amputee when we closed down, I was in Iraq when we closed down Balad there, and we were shifting everything to Kuwait. They had some of those amputees come back from where their initial point of injury. They were following their path back home, and just seeing those individuals and them thanking you for everything that you did for them. It's, I don't know, not much of an emotional person, but having that experience and seeing them come back through that, and being a part of that, it's something that, I don't know, you realize that you're part of something bigger. And being in the military, you are contributing to something that's bigger than you. We've never done a good job selling that.
Well, if this doesn't do the trick, I really do thank you so much. Thank you for your time today. This wraps up our edition of Behind the Breath. And again, heartfelt thank you to James Woods for sharing his stories and just, the powerful insights then and unwavering service that he has provided as a military RT. If today's conversation has inspired you or given you a new perspective on what it means to be an RT, especially in uniform, please share this episode and follow this podcast wherever you listen. And you've been given now also some specific information. You can reach out to James Woods, and I'm sure he'd be happy to answer any questions that you might have. If you're interested in collaborating with other active duty military members within the AARC, as well as members of the Guard, the Reserve, veterans, civil service RTs who work for the VA or the Defense Health Agency, please be sure to join the AARC military community on AARC Connect. We welcome you there. And again, for more information on how AARC supports RTs in every setting, please visit aarc.org. Until next time, breathe easy. And again, thank you so much for today. Really appreciate the chance to talk with you. And thank you for being a part of the AARC.
Thanks for the opportunity.
Have a great day.